again, very theoretical topic, electrodiagnostic studies. So generally, when we have a nerve injury or we have something like a compression neuropathy in the form of carpal tunnel syndrome, or a foot drop, or a wrist drop, or a brachial plexus injury, we'll just try and see whether the patient has a NCV ENG study done. So it's important to understand here that as postgraduates, we generally tend to look at the ENG and NCV before we even have a look at the patient. So it's important to understand that these are not actually ends. These are actually adjuncts to your clinical examination. A very good motor sensory clinical examination will actually give you much more information than actually an ENG and NCV study for anything, for whether it's a nerve injury, whether it's a compressive neuropathy, or whether it's a brachial plexus injury. Nothing can replace a very thorough clinical examination. All the electrodiagnostic studies can tell you these are adjuncts, and they can help you in coming to formulate a theory and formulate a plan in your management. And also it can help you in assessing patients in whom you have repaired nerves, or if you have done some kind of a muscle neurotization or a nerve transfer, to see whether your nerve is recovering or not. So basically, for prognostication and for understanding and assessing how your nerve repair or your muscle neurotization has worked, these studies are very, very useful in relation to plastic surgery. It's not really a diagnostic tool. It's more of a diagnostic tool when you are differentiating a polyneuropathy from a radiculopathy or various other types of motor neuron diseases for a neurologist. When it comes to a plastic surgeon, and when we are dealing with nerve injuries or compressions which require a surgical treatment, these electrodiagnostic studies are not much of utility for diagnosis, but very useful for planning treatment and how you prognosticate the patient. So what are the components of electrodiagnostic studies? So you have, when we have a nerve, we have all read in physiology that you can stimulate a nerve either by mechanical pressure, or you can have a electrical stimulation or a chemical stimulation of the nerve. Moment you have a stimulation of the nerve in this method, what happens is that the membrane potential that is there in the nerve, that gets disturbed. So your sodium potassium channels start opening, closing in a very rhythmic fashion, and you have what is called a change in the membrane potential. And once that membrane potential changes and reaches a critical threshold, the nerve sends out action potential. And what is an action potential is that it transmits or it conducts that change in the membrane potential along the length of the nerve. And that is what is called a propagating action potential. And you can measure this propagated action potential in a live nerve. What I mean by a live and intact nerve is that a nerve which has got a cell body and it has got axons and dendrons that are intact and functioning and viable. So if you stimulate any part of the axon, it will ultimately, and if you stimulate it maximally beyond a particular threshold, it will lead to an action potential or a nerve impulse being conducted. So it's different from electricity being conducted in a tube. So when you have an electric injury, suppose you hold a nerve, you hold a electric wire, a household exposed electric wire, and the electricity passes through your right hand and goes out through your left hand, it's actually being conducted like a tube. You are a conductor of electricity, and it's extremely rapid. But when a nerve is stimulated and the nerve action potential travels along the nerve, it is not that rapid, it is quite slow. It's quite rapid as far as we are concerned, but not as rapid as electrical stimulus is, electrical conduction through a wire is concerned. So we can have nerve stimulation. You can stimulate a sensory nerve, or you can stimulate a motor nerve, and look at how it is conducting and how fast the action potential is getting transmitted through that nerve. And we call that sensory conduction velocity or nerve or motor conduction velocity. In common parlance, this is called nerve conduction velocity, but it's important to understand that these two are different. You can stimulate a motor nerve or a sensory nerve. And you can also look at what is the action potential, that is the amplitude of the upward tick in the nerve action potential, and you can call that a sensory nerve action potential or a compound muscle action potential. That is, and we'll come to the details very soon. You may also use a needle electrode. That is, you can use a needle and put it inside a very fine needle so that you don't hurt the patient, and put it inside a specific muscle like a deltoid or biceps or abductor pollicis brevis, whichever muscle you want to see whether it's working and viable and it's neurotized or not. And then you might choose to stimulate that muscle and see how it responds. Or you might ask the patient to do a voluntary action and see when the muscle is being voluntarily used, what kind of electrical activity is there inside the muscle. So that's what is in common parlance called electromyography. You also have certain electrodiagnostic studies which are called evoked potentials. So you give a sensory or a motor stimulus to anywhere in the body. It can be visual stimulus, it can be auditory stimulus, it can be a sensory painful stimulus, and you use a electrode on the scalp so that the brain activity is recorded. And that is what is an evoked potential. And these are the basic three types of electrodiagnostic studies that are important in relation to plastic surgery. So when you look at nerve stimulation, so you have something that is called a stimulator. This is something that is basically gives a very small voltage of galvanic current, that is a direct current, onto a very superficially situated sensory or a motor nerve. So you can have the superficial branch of the radial nerve, or you can have the median nerve, which is more or less superficial as compared to, say, a radial nerve in the in the groove. So it's very difficult to stimulate that nerve because it's quite deep, and you'll need a lot of electricity to stimulate that nerve. So the patient will be uncomfortable. So you look at a superficially situated nerve, and it's not important that you have to look at the radial nerve in the groove to understand whether that nerve is working or not. You can look at the superficial sensory nerve and come to a conclusion regarding the entire radial nerve, because the nerve is only the dendrite. So the cell body and the axon is high up in the dorsal root ganglion. So you need not have to always do a proximal stimulation. You can do a distal stimulation as well. And there are various ways of stimulating this nerve and trying to see various parameters. So if you stimulate in the, so it is a median nerve being stimulated. So if you stimulate it over here, so you see what happens is that there is the initial immediate pickup by the recording electrode. So this is a recording electrode, the black one. This is a reference electrode, and this is a grounding electrode. So you can forget about the grounding and the reference electrode and just consider this as a single recording electrode. So you stimulate the nerve here, and it goes along the nerve, and and it stimulates the electrode here immediately, because you see it is just the current flowing through a conduit. So it will immediately have a small wave. And then followed by that, you will record the action potential that has traveled along the nerve, and you will have a action potential. If you stimulate it higher up, so it will take immediately, you will get a spike where the electricity has been registered by the recording electrode. But then again, the time taken for the action potential to come from here to here will take a longer time than when it is stimulated at the wrist. So if you see here, so median sensory, if you see it is 13 centimeter, and this is the distance of travel, and you measure the time taken here, and suppose you stimulate here in the elbow, and again you take a curve, that is the action potential that is measured, and you can see the difference in time and the distance. So distance divided by the time, you will know what is the speed of the nerve conduction velocity. So that is the differential speed of measuring the action potential as being registered by the recording electrode when you have given two separate electrical stimuli at different areas in the upper limb or in the lower limb. So that's basically what nerve stimulation is and what nerve conduction velocity is. It's very basic. You can also test the motor nerve, the median nerve, the motor, but your recording electrode, rather than being on the digital sensory branch of the radial nerve or of the median nerve, you'll have to place it on the abduct or on the thinner eminence. So all the thinner muscles will be stimulated by this, and this surface electrode will take up all the action potentials that are measured in the muscle. So the muscle will contract, your thumb will move, and you will record a compound muscle. Why is it compound muscle? Because a multiple number of motor end plates are being stimulated, and many muscle fascicles are being stimulated at the same time. So it's not a single muscle action potential, it's a compound muscle action potential. And so what is recorded? You measure the latency. As we saw, this is the latency. That is from the time you record it till here. It is the latency, and it is called the distal latency if you have recorded it distally. And you also see the amplitude. That is how much has it been stimulated. So the number of axons that are being stimulated will be shown by the uptick. That is the amplitude. So in a sensory nerve, if you are stimulating and if you get an action potential, obviously, how many nerves will you stimulate and how many axons will you stimulate it? Whereas if you stimulate a motor nerve, you will stimulate so many muscles. So if you see a snap amplitude, that is sensory nerve amplitude versus a motor nerve amplitude, the motor nerve amplitude will always be many times larger than a sensory nerve amplitude, and that's the reason why. And of course, conduction velocity depends on myelination. So if you remember physiology, we have saltatory conduction. That is, we have nodes of Ranvier, and the change from the resting membrane potential, which triggers an action potential, jumps from one node of Ranvier to the other node of Ranvier, and that's why it's extremely rapid. In an unmyelinated nerve, which conducts pain and temperature, it's very slow. So what is actually measured by a nerve stimulation study are the myelinated and the large diameter nerves which transmit light, touch, and vibration. So only those. So if you have a patient who doesn't have pain and temperature sensation, but you can still measure those nerves or the activity of those nerves which are actually conducting only light, touch, and vibration. You're not measuring those nerves which are conducting pain and temperature sensation. So now you can understand the difference in what clinically you can achieve and what nerve conduction study can achieve. They are only looking at a very specific variety of nerve fibers in a specific region or location in the body. It is not giving you a global perspective that a complete and thorough clinical examination will give you. So it's and also you can have this something of a variation of the sensory study. This is the orthodromic. So you have digital sensory stimulation here, and the recording electrode is proximally. So it is orthodromic, or in the direction where naturally if you stimulate by touching here, it will go this way. And you can also have an antidromic, that is opposite direction. So you have a recording electrode over the digital sensory nerve, whereas you're stimulating the median nerve over here. So both the methods can be used for your sensory nerve action potential. So I'm sorry for this diagram. It's a very, I mean, it's a sort of like a back of a paper diagram that is done by me, and I apologize if you cannot make out. This is the hand and this is the thumb on the right side. So you have a recording electrode which goes to the computer. So this is a computerized oscilloscope. So if you have electricity, it will go up. If you have low electricity, it will go down. So that's what oscilloscope does. It simply records up and down of electrical activity. So this is what I have tried to see. So you have electrical stimulus through a galvanic current. You stimulate it. There will be stimulus going proximally and distally. If you have a recording electrode distally, you will have an antidromic conduction, and that will be recorded. First, the electrical stimuli will be recorded, that is initial, and then you have a action potential. So it's not like electricity in a cable, it's totally different. And there's something called an F wave, which also you need to know, because if you have an F wave, so if you stimulate a nerve here, and it will go all along your dorsal root ganglion through the spinal cord and come back, and again it will come and hit your recording electrode. So after your initial spike and then your action potential, after a very long time, you have a small F wave, and that tells you that okay, the entire nerve, the reflex pathway, that is a sensory nerve going right up to a DRG and through the spinal cord, actually is intact. And this is not important from our point of view, except for certain neuropathies where you have to rule out radiculopathy. So if you have the F wave, it means that it is not the nerve root, or it is not a cervical compression or a spinal cord compression that is causing the compressive features. It is actually somewhere else, more distally. So again, you have the same picture showing antidromic and orthodromic way of this thing. And this is how you record the CMAP. So you have this is for carpal tunnel syndrome. You're trying to do the CMAP. So you've done it at the wrist. You've done it at the wrist, and you have stimulated at the elbow, and you see the change in the action potential. So if you have a gross reduction in the action potential in both the tests, whether it's at the wrist or at the elbow, and you don't have as good a action potential as compared to the other hand. So likely there is a compression over here. And you can also measure the conduction velocity of the nerve if it is normal in the median nerve. So it's not really important to measure the even if you measure the conduction velocity, it may not be accurate rather than measuring the action potential when you have a compressive neuropathy over here. So this again is the CMAP curve and the SNAP curve as that we have already discussed. And this is another study of the median nerve. So you have the stimulation at the wrist, which is like that, and the distance latency is small, and from the elbow it is further off. And although it says normal, it's not really normal because you have variations from lab to lab, and you must compare with the other limb to have meaningful conclusions. So this picture just shows median nerve. You can use sensory motor fibers and how to do the median motor sensory, the ulnar sensory. So you put it on the recording electrode is on the digital sensory nerve, and you have ulnar nerve here. And for the motor, you have the recording electrode on the hypothenar, and then you can stimulate it here. So it's very logical the way you have to record using surface electrodes. So it's not there's no real normal values. And so if you have more than 50% difference in amplitudes, then obviously it's something significant you have to look into. And also if there is a difference of 0.2 to 0.3 milliseconds, you look into it that whether it's important, this distant latency. So these are the various things. And if you look at brachial plexus injury, it's very important to understand that you need a absolutely normal normal axon and cell body and dendron to have a normal snap. So even if you are, if there's a nerve root avulsion right from the spinal cord, so you have the nerve root, the dorsal root is avulsed, even then your cell body is intact. And if you do a snap test in this situation, that is why you might just get a very normal snap recording if you have done it very early on in the if there is no degeneration in this nerve. So you'll have a normal snap because the snap and the action potential are features of a viable nerve root. That is, there is some axon, there is protein and other electrolytes that are being transported along the axon and the dendron from the cell body. So if you have protein and other stuff that is being transported along the nerve body, and if you stimulate that nerve is viable, and so that snap will record, that action potential will record. But if you have a ramus rupture, that is, if you have a rupture injury, not an avulsion injury, in that situation, you will not have the transport of protein and other materials from the cell body. So if you don't have that transport, how will the action potential be generated? You might get it only when the avulsion injury is there. That is, so whenever you have root avulsion or a preganglionic injury that is proximal to the DRG, you will have preserved snap, and that is very important to prognosticate in a brachial plexus injury patient. If you don't have any other features and you are suspecting that it might be rupture, you might be getting a tinel sign when you tap on the supraclavicular fossa. So it's important that you try and look at this snap, whether it's recordable or not. So it's also another cartoon showing the same thing. So if in a normal snap with preserved everything, if you have preganglionic lesion, you might still have the cell body intact and you have a normal snap. But if you have it transected through the nerve, even if you have, whether it's brachial plexus or you have a nerve injury wherein you have transection of the nerve in the upper arm or a transection in the axilla, you have a normal snap because it cannot work. So that's more or less about the nerve conduction and amplitudes and other things, and we pass to electromyography. So what is it? It's basically to see whether the muscle, the integrity of innervation of the muscle is intact or not, or whether the integrity of innervation of the muscle is coming back or not as far as after nerve neurotization or muscle neurotization is concerned. So needle records only action potential in a very small number of motor neurons. It's a very fine. It's a very fine needle that you. So this is in carpal tunnel. So your needle is going straight into the abductor pollicis brevis muscle. So it's a very fine one. So a very small number of motor units are stimulated, and then you can record it. So this is a so you can record it, record using the same needle electrode after you stimulated. So it records the movement in the muscle, and this is a neutral grounding electrode. The same way, if you look at the compound muscle action potential that we were measuring in the nerve stimulation studies, it's different because it's a surface electrode. So CMAP and SNAP are by surface electrodes, and that's why it's a compound muscle. Many muscles are being stimulated, but here it's a very small number of muscles that are being stimulated in an EMG. So if you want to look at deltoid, you can say that I want to look at EMG of the deltoid after I have re-innervated the axillary nerve. Or if you have re-innervated, you've done an overlaying procedure, I want to look at only biceps, you can use the nerve, needle EMG. But then again, you have to poke at multiple parts of the biceps to see whether your muscle is getting re-innervated or not. So EMG findings after nerve injury. Let us look at this EMG. If we have a proximal nerve injury and the nerve is denervated, what are the EMG findings? So in a normal muscle, when you insert the needle, you will see spikes, because the moment you're inserting, the muscle will get irritated and it will start contracting. It is just like tapping your muscle. If you tap your muscles, we are taught during our debridement that if a muscle is viable, you tap on the muscle and it immediately contracts. So it's the same thing. You put a needle inside, it will contract, and that will get recorded. But if you put it in and if you are at rest, that is, you're not stimulating the muscle, there will be electrical silence. The muscle will not move at all. That is, if you open a gracilis, if you cut the skin and the fascia and you touch the gracilis, it is not going to move or it is not going to contract. But the moment you tap it, it will have spikes. And of course, if you ask the patient to contract, it will have an action potential exactly as you're supposed to have. It will have a triphasic, like it will go down and then up and then come down. And then come back to resting potential, exactly the way we are taught in physiology of a single axon, how a action potential works. And because it's a very small number of muscle units that are being activated, you will get a very nice action potential. In early denervated, that is, muscle has been denervated very early, you will get no spikes when the needle is inserted, because the muscle is not innervated at all. It is already denervated muscle. Same thing you see when sometimes you have you're raising an anterolateral thigh flap and you have to divide the nerve. When you are actually dissecting the perforated, the vastus lateralis keeps on jumping up and down, and you ask the anesthetist to give some more relaxant because the muscle is jumping. And then you have, once you divide the muscle, you see that the vastus lateralis is no longer jumpy. So it's the same thing. You stimulate it, you might have some positive sharp waves that you see on electrical activity. So, and of course, there is no voluntary action for an early denervated muscle. And eventually, after a year or so, when the denervated muscle becomes completely fibrosis, you will get no spikes when you insert the needle, and you will have absolute silence when you put it inside. So there will be nothing. There will be nothing when you have denervated muscle after 1 year. But if you have a muscle where you have repaired the nerve or you have neurotized the muscle, the moment you insert the needle, you will have some spikes that you will see. And of course, you will have a decrease in the fibrillation. That is, if in the early denervated muscle, you always have fibrillation potentials, and these are local changes in the muscle potential when the muscle is being fibrils are being stimulated. So as these muscle get re-innervated, these fibrillation potentials will decrease, and you will have very small amplitude, tiny action potentials that you will see. So this is how you interpret an EMG after you have a nerve injury and then it gets repaired again. In brachial plexus also, it's very important. So what you have to understand is that paraspinal muscles get innervated from the roots, the ventral roots, rather than from the ventral rami. So spinal cord, dorsal root, ventral root, spinal nerve, and then spinal nerve divides into ventral ramus and dorsal ramus. So if you have paraspinal muscles that are denervated, then those roots, then it must be an avulsion injury. That is, it is proximal to the spinal nerve. It is in the roots. But if you have a ventral ramus that is injured, so that in that case, you will not have the EMG of the paraspinal muscles will be preserved. So denervation of paraspinal muscle is a sign of motor nerve root injury and not ramus injury. So as I already said, how there are various ways to see how the motor nerve recovers. There are certain things called recruitment and interference pattern analysis in the EMG as well. So with minimal, maximal and moderate amount of voluntary contraction, various things are seen in the recruitment patterns, that how many motor units are getting recruited or how much is being built up, and accordingly you can assess how much is being how much recovery is happening in your muscle. It's also important to know that EMG is very sensitive for assessing the degree of renervation. But you should not do an EMG very early on or an NCV very early on after injury, especially after brachial plexus, because you might get something, you might have an avulsion injury and you might have certain, the synapses still having certain proteins. As a result, you will still have false positive and false correct EMG and NCV results if you do not wait the adequate amount of time. So so how do you diagnose a nerve injury? And we come together with all the parameters, the SNAP, the CMAP, the NCV, and the EMG. So when you have neuropraxia, you will have the SNAP and CMAP amplitudes reduced with proximal stimulation, and you have reduced conduction velocity, both sensory and motor. And you will have sparse fibrillation. If you look at the muscle that the nerve is supplying, you will have characteristic fibrillation, or you'll have no fibrillation and a characteristic interference pattern. Whereas if you have your axon divided, you'll have the amplitudes of the action potentials reduced, and you may have a normal or reduced nerve conduction depending on the number of axons that are surviving. That is, if you have partial injury, you will still have some nerve conduction, because whatever nerve is remaining, whatever axon is intact, will give a normal conduction of the nerve stimulus. It does not matter whether 100% of the axons are there or only one axon is there. It will still give you a normal conduction velocity, because that one single thing, one single nerve will conduct that stimulus. But yes, of course, your amplitude of the amplitude or the max amount of action potential or the peak or the trough that you will reach will be definitely low. And in an EMG, it depends on the stage of denervation and renervation, as we already discussed. But if you have a complete neurotemesis, you will have no conduction velocity, and that's for sure. And you will have profuse fibrillations of the muscle at rest. And there will be no voluntary muscle unit potentials. So we come to the end of the EMG as well, and the NCV and other things. And just for completion's sake, evoked potentials are also is not very easily available tests in India. But I mean, from the point of view of plastic surgeons, but we of course have visual evoked potentials and auditory evoked potentials, where you stimulate the eyes or you stimulate the ear, and you place electrodes over the scalp to see if the brain is being stimulated or not, especially in kids. Kids who are less than 1 year or a month old, you don't know if the brain is actually receiving the sensory stimulus or not. So if you give a visual stimulus and the brain lights up, and the brain doesn't light up, brain gives electrical stimulus, then that means the child or the small child or the neonate is having some intact pathway, and the prognosis is better than others. As far as plastic surgery is concerned, we can have motor as well as somatosensory evoked potential. And this is basically to find out if the status of the proximal nerve stump. So if you stimulate the proximal nerve stump, you can have an evoked potential in the brain. And you can also, especially in the case of postganglionic lesions, where the spinal nerve stumps are seen, you may not know whether the stumps are adequate for rejoining to the distal stumps or not. So if there is absence of the evoked potential, it means that there is also, in addition, a preganglionic injury, and therefore the stump cannot be used for nerve coaptation. It's not computation, it's coaptation. So I hope you understand that if a nerve stump that you are seeing after you explode the brachial plexus, that is a proximal nerve stump, and you think that, okay, I can join the distal nerve and excise the neuron and join them too, it may not work, because if you use a somatosensory evoked potential, if you stimulate the nerve and if you don't get a stimulus in the brain, that means there is no conduction from that proximal stump to your brain. So even if you join it, it might not work at all, although you've done a great surgery and joined the stumps. So that's also very important. Thanks.